I'm so happy to be able to engage in this important topic tonight. So we'll go to the first slide. So as we know, breast cancer is the most common malignancy in adult females. And for more than 90% of women, surgery is an important part of their treatment. Surgical therapy involves breast surgery and, when indicated, surgery to the axilla as well. Breast surgery includes lumpectomy in the form of breast conservation surgery with or without oncoplastic techniques, or mastectomy with or without reconstruction. Where axillary surgery is indicated, that can include sentinel lymph node biopsy, targeted axillary dissection, or an axillary lymph node clearance. And what we know is that surgery is a highly effective treatment in achieving disease control in women with breast cancer. Next slide. We also know that surgery can result in physical and psychosocial effects as well. And these effects may last for months or potentially years after treatment. The regional postoperative effects include lymphedema, pain, axillary web syndrome, and upper quadrant dysfunction, really defined by a loss of strength and range of motion, particularly in the shoulder. Whole body adverse effects include most notably fatigue. We know as well that the severity of these adverse effects varies, and it occurs across a continuum, where for some patients they may have none or mild effects, whereas other patients might have such significant effects that it impacts on their quality of life. And what we know is that it's dependent on a number of factors, which include age, comorbid conditions, treatment regimen, and baseline physical well-being. And what you will note from this is that some of these factors, such as age, is something that we can't modify. But another factors, say baseline physical well-being, is actually modifiable, and we could potentially influence that. As a surgeon, the top priority is to achieve the best outcomes for patients from surgical treatment. So these potentially modifiable factors that potentially could influence the outcome of surgery are very important to consider. And it leads me to the evolution of the surgeon. So historically, the surgeon was really an individual working within a silo. But now, as we're moving towards greater complexity, which is being driven by highly individualized treatment regimens, the modern surgeon is definitely a member of a comprehensive cancer team. Next slide. And so what does this breast cancer team look like? Well, it might look something like this, and definitely at least the cancer team consists of the breast surgeon, medical oncologist, and radiation oncologist. And definitely the leadership provided with the team can be variable, but certainly in Australian practice, I believe that it is the breast surgeon that commonly provides this leadership. And it's mainly because when a patient is diagnosed with breast cancer, the first breast cancer specialist that they're generally exposed to is the breast cancer surgeon. And it's really at this initial consultation where the patient appreciates an understanding of their treatment trajectory and potentially who might be involved in their breast cancer journey. Next aspect. And as we delved into the evolution of the surgeon, the breast cancer team has also evolved to more complexity and comprehensive care, including physiotherapy, occupational therapy, rehabilitation, and nutrition, and social services, to name a few. And this is because we're facilitating this highly individualized care because we know that it's associated with best outcomes. So if we were to piece all of that together, the modifiable factors, the surgery, and the team, it naturally concludes that facilitating the best outcomes from surgery starts before surgery, and that the imperative is to have a multidisciplinary approach from the beginning. So in addition to an excellent operation, the surgeon must also be excellent at utilising multidisciplinary expertise. And what are some of the potential things in which this multidisciplinary approach may look like and may enable? Well, firstly, it'll enable baseline holistic assessment, both in terms of the clinical disease characteristics, but also the physical well-being and psychosocial well-being of the patient. And as those baseline holistic assessments are made, it allows for identification of the health needs of the patient and thereby refinement of the treatment pathway as well, because identifying the health needs unique to each patient implies a very unique treatment pathway. So you can imagine that as the patient is engaging in this baseline assessment and identification of their health needs, it leads to an improved understanding of their health and cancer journey as well. Traditionally, what we may expect the patient journey to look like is that there's an initial consultation, and then it proceeds straight away to surgery with an associated recovery and long-term follow-up. But if we were to add in the multidisciplinary approach from the beginning, it might include baseline measures as well as actions. Next slide. Both in nutrition, physical exercise plans, as well as the psychosocial well-being. Next slide. So what does this all imply for a patient's recovery and long-term outlook? The evidence suggests, and this is cumulative evidence, both in patient groups affected by breast cancer, but also patient groups affected by other cancers, that where there is higher levels of preoperative aerobic fitness, it is associated with decreased postoperative complications and potentially improved disease-free survival. Where there is baseline body composition assessment with regular surveillance on follow-up, it allows for earlier identification of lymphedema with better therapeutic outcomes. And where there is high levels of psychosocial well-being, it's associated with higher satisfaction reported by patients after surgery as well. So the role of the breast surgeon is twofold, one within the operating theatre and the other within the multidisciplinary team. And what's really important to acknowledge is that this is a space which is associated with a current burgeoning of research. And certainly the understanding with respect to how best prepare patients before surgery is evolving. And there's still so many questions that we need to answer, which future research will address with respect to the different regimens and in particular the optimal regimen in the lead up to surgery. But ultimately, I do believe that it is the surgeon who takes leadership both in the operating theatre and within the multidisciplinary team to facilitate multiple expertise and specialists involved in the breast cancer care of a patient to facilitate the best outcomes for patients.